This is part 3 of Chapter 12, Diseases and Conditions of the Reproductive System. And we begin here talking about the female reproductive diseases, and there are many conditions, abnormal conditions and disease conditions of the female reproductive system to describe here. Certainly some of them are infectious as far as microorganisms invading the tissues. There could certainly be tumors, either benign or malignant, affecting the system. And there are symptoms that when a female has these particular symptoms, these symptoms should be investigated to make sure that things are normal, or to find out what's going on as far as abnormal. Any vaginal discharge with or without odor needs to be investigated. Lower pelvic or abdominal pain. And then there's also a listing of certain pelvic symptoms, such as menstrual pain, which is dysmenorrhea, painful menstruation, amenorrhea, which is absence of menstruation, menorrhagia, which is bleeding between menstrual periods, and metrorrhagia, which is bleeding. Oops, I said that wrong. Let me back up. The metrorrhagia is bleeding between the menstrual periods, and the menorrhagia is excessive or prolonged bleeding during the time of menstruation. Menorrhagia, excessive bleeding during menstruation. Metrorrhagia, bleeding between menstrual periods. There's also the oligomenorrhea, which is scanty menstruation, where the person is menstruating very little. We're going to begin with the first condition, and I can't call it a disease. I'm just going to call it it's hard to even call it an abnormal condition because it is so common, and that is premenstrual syndrome, PMS. These symptoms, this syndrome occurs around the time shortly after ovulation, just before the actual menstrual period begins, and it's due to a fluctuation in the hormone levels, and it can cause many different symptoms, altered mood, symptoms of tension, irritability, headache, fatigue, restlessness. There's a number of different symptoms a person may have: breast tenderness, joint pain. Some may have edema, which is swelling, a feeling of bloating or abdominal pain. They may even experience extreme anxiety and anger, or extreme sadness, fatigue again, irritability. If these conditions are severe, they need to be investigated or evaluated by a physician. There are some medications that can help to treat these symptoms. If it's very severe and the person meets certain psychological criteria, the diagnosis may shift from a simple premenstrual syndrome to a premenstrual dysphoric disorder, PMDD. In your book, they describe some of the treatments directed towards a relief, a reduction in the intake of sodium and salts, increased calcium consumption, moderate exercise should help relieve some of the symptoms, mild analgesics, diuretics, and again, emotional support, and just kind of understanding for a person's, I guess I'm going to say, partner, to understand that premenstrual syndrome, PMS, is a true physical problem because of the hormones being produced, and it's not just in a woman's head kind of thing. It is in her head. It makes her feel very irritable and have headaches and fatigue, and it's very real emotional symptoms that go along with the PMS. So the symptom, also eliminating caffeine may help a person as far as the breast tenderness and some of these symptoms. Antidepressants may be needed if the person truly meets the criteria for the PMDD. Okay, after the description, let me back up from where I am on this screen. After the description of premenstrual syndrome, the description of amenorrhea is given there, And I actually described amenorrhea on the previous slide that I'm going to work my way back to. And it's listed here as if it's a disease in itself, but as far as I'm concerned, the amenorrhea is a symptom of something else that's going on, such as it may be that a person has a severe hormonal imbalance. It's not so much a concern, this absence of menstruation, until a person is age 16 and still has not had a menstrual period. And then evaluation needs to be done to find out what's going on there. Certainly if the person is pregnant, they may have amenorrhea. Amenorrhea may also come on after a person's had some menstrual periods, and they may stop having menstrual periods. If they are without menstrual periods for 2 or 3 cycles, it needs to be investigated to find out what's going on there. Some amenorrhea has been identified as associated with thyroid disease, excessive weight loss, excessive athletic training. Psychological stress may also, and certain mental disturbances may induce the amenorrhea. So the treatment is going to be directed at whatever the cause is. Dysmenorrhea is also listed here as if it is a diagnosis to stand on its own, but it's really a symptom of something else going on. The dysmenorrhea is painful cramping at the time of menstruation. And it could be completely normal because many people do have the extreme discomfort with menstruation. It could be a symptom of having endometriosis, which I'm going to talk about in a few minutes, and fibroids and some of these other female abnormalities. So treatment again is directed at whatever the cause may be. Okay, I'm going to move on to following the book to talk about the ovarian cyst, which there is a really good picture in your book of an ovarian cyst. In your book, they're showing a good comparison of the ovarian cyst as compared to the size of a normal ovary and a normal uterus. The cyst can become extremely large in some cases. Fluid-filled sacs on or near the ovaries. They may be malignant. More of them are benign. Most of the small cysts, in fact, will be completely unnoticed by the patient. They'll be asymptomatic. As the size of the cyst increases, the symptoms are going to increase, where the person will have some pain. Rarely they're going to have urinary retention. If the cyst is actually grown large enough to put pressure on the bladder, they may have problems there. If the cyst twists, if it causes a twisting or torsion, it's going to cause some really serious pain. That is the kind of pain that makes the person go in the emergency room and have emergency surgery. More likely the person's just going to have some pain associated, and then investigation needs to be done using ultrasound, using CAT scans. Sometimes a laparoscopy may be necessary, and if appropriate, the ovary and the cyst may need to be removed. It depends on whether the person is still of childbearing age and may want to have babies someday. They may not remove the ovary completely. So a lot of factors go into what treatment may be implemented for the ovarian cyst. Okay, under endometriosis, there's a great picture in your book of showing where the sites of endometriosis may occur. The endometrial tissue is actually outside the uterus when a person has endometriosis. Looking at the picture in your book, the little green marks there show where this endometrial tissue may escape to. It may be found out in the fallopian tube. It may be even on the colon itself. It may develop in the cul-de-sac between the colon and the uterus. The endometriosis may cover the fallopian tube. It may cover the ovary. So there's a lot of different places for the endometrial tissue to gather outside the uterus, and the symptoms depend on how severe that accumulation of endometrial tissue outside the uterus actually is, and the site. There's probably going to be some dysmenorrhea, some abnormal bleeding, whether it's menorrhagia or metrorrhagia, cramping, maybe even pain during intercourse. And the endometriosis can cause some pretty serious problems like infertility. A person may not be able to get pregnant because of the presence of the endometrial tissue outside the uterus. Ectopic pregnancy may occur, and I'll talk about that in just a few minutes, and spontaneous abortions. It's as if the menstrual material, the endometrial tissue that should be shed, actually moves backwards through the fallopian tubes and out into just the peritoneal cavity there. Risk factors include a family history of the disease, menstrual cycles that are shorter than every 28 days, or those, on the other hand, that last longer than 7 days. Uterine structural abnormalities may interfere with the normal menstrual flow out of the uterus. Fibroids, which are benign tumors of the uterus, may result in endometriosis. To diagnose this condition, ultrasounds can be done. Laparoscopy may be used to look around and to actually remove some of the endometrial implants. Depending again on a person's age and whether they want to continue to have babies or not, the treatment could be very conservative with hormones and other conservative treatment, or if the person is beyond childbearing age and they do not want any more children, then a hysterectomy may be performed. I've listed here a hysterectomy with bilateral salpingo-oophorectomy, and that would be bilateral, both sides, removal of the fallopian tubes and the ovaries. Salpingo being the fallopian tubes, oophor being the ovaries. But again, it depends on the person's age whether they need to have more conservative treatment. I like under treatment that they tell you that although there is no cure, that pregnancy, nursing a baby, or menopause brings remission of the symptoms. It's kind of like, well, okay, the cure is to get pregnant, but you've got to be ready for those long-lasting effects of pregnancy too. And menopause, that's when everything's going to stop or slow down anyway. Very often, if a person's suffering from endometriosis, they're not going to be able to suffer through the pain and uncomfortable feelings through menopause. They'll usually have surgery earlier than that. Okay, that's endometriosis. The next topic here is pelvic inflammatory disease, PID. An infection of a woman's pelvis. Most of the pelvic organs will be involved there, certainly the fallopian tubes and the ovaries, surrounding tissue there. There may be even abscess formation, and most of the cases of pelvic inflammatory disease are due to sexually transmitted bacteria, the chlamydia or the gonorrhea. So antibiotics may be appropriate treatment. It depends on how widespread the infection is. The person may end up having being sterile from the scar tissue in the fallopian tubes. They may end up with peritonitis, this inflammation, overwhelming inflammation and infection in the peritoneum. They may even develop septicemia because of the overwhelming infection with these bacteria causing pelvic inflammatory disease. So early diagnosis and prompt treatment is so important to prevent the damage to the reproductive system and also to prevent the spread through the body. Again, antibiotic treatment and the pelvic inflammatory disease may actually recur. I like that your book says under prevention, the best prevention of PID is to not acquire a sexually transmitted disease. Because again, that's the most common cause for PID is a STD. aggressive antibiotic therapy, analgesics, bed rest, all of those being very important in trying to combat the pelvic inflammatory disease. Okay, next condition here, benign uterine tumors. Benign uterine tumors, which are referred to as leiomyomas. A more common term that you may hear would be fibroids. The fibroids are benign uterine tumors. The more official name is leiomyoma. The word parts there, oma is a tumor, my is muscle, and the lyo is a smooth muscle. And the uterus is certainly a smooth muscle. It's an involuntary muscle. The person that has these tumors may be completely asymptomatic, not realize they have the tumors, or they could have severe bleeding at the time of menstruation or between menstrual periods. They may have pelvic pain, constipation. Treatment depends on the severity of the symptoms, and again depends on the person's age. In women of childbearing age, surgery could be performed just to remove the tumors. In the woman that's not going to have any additional children, then hysterectomy would be the treatment of choice. Hysterectomy being removal of the uterus and therefore removing the tumors. The next condition to describe here is vaginitis, which is inflammation with infection of the vagina. Symptoms include itching, burning, vaginal discharge. The most common cause for the vaginitis is a fungal infection. Could be a sexually transmitted disease causing the symptom of vaginitis, so the treatment depends on the cause. And the cause can be specifically diagnosed with the cultures being taken of the vaginal discharge, and then appropriate antibiotics and treatment given from that point. Okay, look also at toxic shock syndrome, acute systemic infection with Staphylococcus aureus. Staphylococcus aureus is the organism. It's a very severe infection of many systems in the body, and it is associated with the use of super absorbent tampons, and tampons being left in place for too long. The toxins produced by the Staphylococcus aureus may actually build up because of the superabsorbent tampons left in. When a person has toxic shock syndrome, it's a systemic, so they're going to have a systemic infection with high fever, headache, sore throat, rash. It may be so severe that they develop neuromuscular disturbances, abnormal kidney function, their liver enzyme levels may be elevated. Without treatment, this is going to be a life-threatening condition. It may actually be fatal. But certainly with treatment, with the appropriate antibiotics and the appropriate immediate treatment, then the prognosis can be very good. Treatment with the appropriate antibiotics is key here. Usually, again, a menstruating female that's been using the superabsorbent tampons with these signs and symptoms, and it rapidly progresses to hypotension. Now, mark that as hypotension. That's low blood pressure and shock that goes along, hence the name toxic shock syndrome. So they certainly need someone to immediately realize exactly what is going on in the situation to treat them effectively. Interesting under prevention, although the synthetic fiber composition of tampons has changed since toxic shock syndrome was first diagnosed, physicians advise women to use tampons that are just absorbent enough to handle the menstrual flow and to avoid the superabsorbent type. They are best used during the daytime and should be changed frequently. Storing tampons in a cool, dry area also helps to reduce the environment for bacterial growth. Okay, next condition to talk about is menopause. Now, menopause is not a disease, though the person may think that they have contracted some kind of disease when this it's not even an abnormal condition. It's a normal condition that occurs with aging. It's the natural process for the ending of the menstrual cycle. The average age of menopause between the ages of 50 and 51 could occur anytime after the age of 40. People will have the symptoms of sometimes psychological, anxiety, poor memory, sleep disorders, depression, loss of interest in sex. Once a person has stopped menstruating, they're considered to be postmenopausal. They're considered to be menopausal, and it sometimes takes a year or two maybe to go through the process of menopause. There are treatments just to kind of manage the symptoms, just to help the person get through the hot flashes and the other changes that are related to estrogen decreasing in the body. It's even referred to as estrogen withdrawal, because the woman who has been accustomed to a certain amount of estrogen every month, her body naturally reduces that amount to almost no estrogen being produced, and therefore develops these signs and symptoms. As far as treatment, weight-bearing exercise, dietary calcium are important to help the person not lose too much bone during this time period. Estrogen is important for bone resorption, for the bones to be hard and strong and thick as they should be. A condition called osteoporosis may develop in menopausal women and in postmenopausal women. So it's really important for evaluation of their bone health as a person goes through menstruation. Also on the same PowerPoint slide, I have a uterine prolapse and cystocele described, and rectocele. They're all kind of related, and just because I don't have very much at all on the screen about them doesn't make them any less important. When we're looking at uterine prolapse, the uterus literally drops down out of place. You can see from picture 1 to picture 2. Here's picture 1 where the uterus is in the normal place, and it will drop and drop and drop to literally dropping out the vagina. That's prolapse of the uterus. Most patients with a mild degree of the prolapse will have no symptoms. They begin to feel pressure as the prolapse becomes worse and worse. Sometimes can have pain with intercourse, and sometimes just a general pelvic discomfort because of the prolapse there. It occurs when the normal support of the uterus weakens from trauma, like in childbirth, aging, and also genetic factors can contribute to the prolapse of the uterus. As far as treatment, there's no way to have the prolapse reverse itself once it's occurred. Even though the person may lose weight and try to avoid constipation and a few other things, there's the use of a device called a pessary, which may help women with the symptoms of the prolapse, but it really doesn't correct the problem. Surgery is the only true way to correct the prolapse, and it may be that just the person needs to have a hysterectomy just to completely remove the uterus. In the case of the cystocele, there's a great picture in your book comparing the cystocele and the rectocele. Cystocele, there's a protrusion and herniation of the urinary bladder into the vagina. Causes the patient again to have pelvic pressure, maybe even have bladder symptoms in which they have urinary leakage or urgency. May again be due to trauma during pregnancy and childbirth, and there's some genetic predisposition. Surgery could be used to return the bladder to its normal position, but the person has to also consider things like weight loss and strengthening those muscles to prevent the cystocele. Rectocele, it's the rectum that herniates into the vaginal area. And again, there's a surgical repair that can be performed to correct this herniation. Okay, now I want to talk about the cancers of the female reproductive system and start with a description of cervical cancer. The cervical cancer, as you see here on the PowerPoint slide and read in your book, it's one of the easiest cancers to diagnose. It's diagnosed through the annual pap smears that women, once they become sexually active, should have a pap smear every year. The pap smear is not going to prevent the cervical cancer, but it's going to be a way of diagnosing the cervical cancer at an early stage when hopefully it's still just in one small area. When it's hopefully in just one small area, it hasn't metastasized to another area. The very earliest stage of cervical cancer is referred to as carcinoma in situ. It's in a very small area when it's first identified, and then only that small area can be removed, and hopefully that will be all the treatment necessary, but there is a chance that it may recur. There may be association, or there usually is. Let me go with that. There's in about 98 to 99% of the cases studied of patients that had cancer of the cervix, they also had HPV. They also had history of having those genital warts caused by the human papillomavirus. So treatment, again, usually surgery. They may need radiation therapy. They may need chemotherapy, and it depends on the stage of the cancer, exactly what treatment and what the prognosis will be. The vaginal cancer is actually a very rare cancer. The vaginal cancer is associated with the use of I want to say chemical, but it was a medication called, just referred to as DES. Okay, it's not just referred to as DES. It has a longer name that I'm not real good at pronouncing. It's a synthetic hormone that was once given to pregnant people to prevent miscarriages, to prevent spontaneous abortions, miscarriages, and also given to manage diabetic pregnancies. They found out later that this type of cancer, vaginal cancer, is very likely to occur in daughters of mothers who received the DES during their pregnancies. Vaginal cancer is rare except in this particular group of people in which their mothers received DES when their mothers were pregnant. So certainly since that time, the use of DES has been discontinued. The treatment is going to be dependent on the location, the size, and the stage of the tumor. Surgery is usually going to be a part of it, and usually just a full-blown hysterectomy to remove the vagina and the uterus and all parts there. Again, depending on the stages, and the person may have to have chemo, may have to have radiation. The next cancer to look at is labial or vulvar cancer. And when a person has cancer of these external genitalia, it's usually a skin cancer like squamous cell carcinoma. Usually occurs in postmenopausal women. Most of the patients will notice a nodule or some type of lesion on the labia or the vulva, and they may have itching associated with this. And then, of course, when they go to the doctor and they describe what's going on, a biopsy will be taken, and if it is truly positive for the cancer, the usual treatment is surgical removal of all the skin in that area, removal of the vulva itself. May need radiation therapy. Again, it depends on what stage the cancer is in when it is actually identified. The vulvar cancer has also been identified as being associated with the genital warts and the HPV. Ovarian cancer. Ovarian cancer is one of those considered silent cancers that the person doesn't usually have signs or symptoms until it's too late. Very often asymptomatic until the very advanced stages. And then by the time the advanced stages, the person may already have metastasized to major organs in the body. We do know that there are certain groups of people that are more likely to develop ovarian cancer. That's women between the ages of 40 and 65. Pregnancy, breastfeeding, prolonged use of oral contraceptives, and tubal ligation may actually reduce the risk for ovarian cancer. Women who have had breast cancer or who have a family history of breast or ovarian cancer have an increased risk. People who have a certain type of colon cancer, non-polyposis colon cancer, also have an increased risk for ovarian cancer. The treatment of the cancer is going to depend on the stage it's identified. Certainly surgery will be part of this treatment. How extensive the surgery will be is determined by whether the person is still of childbearing age when they're diagnosed. And usually they're not, because it's usually people over the age of 40. Usually they'll have a hysterectomy with the bilateral salpingo-oophorectomy. Just doing a total hysterectomy there with removal of ovaries and tubes. Again, if it is diagnosed late, which it very often is, the person will have to have some chemotherapy, maybe even radiation therapy, but most likely it's going to be chemotherapy to try to control the sites of metastasis. Okay, now looking at uterine cancer that occurs mainly in women of menopausal age or postmenopausal women, usually in the ages between 50 and 60, and the major symptom is that they begin to bleed after menopause, postmenopausal bleeding. Treatment's going to be surgery, the hysterectomy, and or radiation. Again, it just depends on how far the cancer has progressed when it is identified. Hopefully the postmenopausal woman, when she realizes that bleeding is occurring, will go immediately for treatment and evaluation. Most people, again, are around the age of 60, 61 when they're diagnosed with this. And the person who has had no children and never used oral contraceptives are more likely to have the endometrial carcinoma, just like they're more likely to have ovarian cancer. Okay, I'm going to end this part 3 at this time, and then when I pick up with part 4 of chapter 12, I'll begin with pregnancy.